The Alcohol Occasionals have been running as an annual programme since 2013. They provide the chance for researchers, practitioners and policymakers and members of the public to hear about alcohol-related topics and discuss and debate implications for policy and practice. And today's event is the second in this year's series focusing on alcohol through the life course. And I'm just going to share my screen with you for a moment, which shows you, so that's today's session. I also want to draw your attention to the next sessions, which are on 23rd of June, where the focus is minimum unit pricing in Scotland, drawing on a qualitative study of children and young people's own drinking and related behaviour. And that's research that was commissioned as part of the evaluation of minimum unit pricing in Scotland. And then on 7th of July, problematic substance use in later life with Dr. Trish Hafford-Litchfield from Strathclyde University. And just to say, we're extremely grateful to the speakers for our sessions, that they've managed to arrange things so they can actually do these for us online. I also want to advertise a couple of other events which I think may be of interest to people. The first being on 28th of May, which is the final session of the Focus on Youth Football and Alcohol project, which is an EU-funded project looking at how to reduce heavy episodic drinking among young people and recommendations in relation to alcohol in sports across the EU. This is an EU-funded project, and you're very welcome to join that, and details there. And also on 3rd of June, SHAAP and the Institute of Alcohol Studies, the final session of our seminar series on men and alcohol, again being held as a webinar from 2 to 4 p.m. Just go onto the SHAAP website for more details of those and how to register. Okay, so just talking about today's session, today's presentations will last around 45 minutes, with the rest of the time and finishing no later than 4 p.m, with the rest of the time being given over for discussion. As far as possible, I would ask you to help us focus our discussions on recommendations for policy and practice, which we can include in our report. So the focus of today's discussion is fetal alcohol spectrum disorders, and preventing FASD and supporting affected families is extremely important to all of us. We are delighted that we've got so many people joining us today, and that includes several colleagues from other countries. I just wanted to make a point that I think is really important, which is that when we're discussing these issues, that we avoid contributing to stigma against people affected by FASD. And so I would ask that we can all be as careful as possible, not to make kind of some of the casual comments which I have sometimes heard about facial characteristics that we think might indicate FASD, particularly among certain populations. I think that that is kind of really not helpful and can contribute to stigmatizing attitudes, which is not what we wish to do. So I'd appreciate if we can just watch that. So passing on to the speakers, I'm pleased to introduce Dr. Sarah Brown and Dr. Jennifer Shields. Dr. Sarah Brown is a consultant paediatrician based within Rainbow House Child Development Centre, NHS Ayrshire and Arran, which for those from other countries, that's the south-west of Scotland. Sarah's the lead clinician for the Scottish Government-funded Fetal Alcohol Advisory and Support Team, and she's committed to supporting the nationwide development of FASD services and improving clinician confidence in diagnosis of FASD. Dr. Jen Shields, who works alongside Sarah, is a principal clinical psychologist for the Scottish Government Fetal Alcohol Advisory and Support Team and also based in Ayrshire and Arran. She is the research lead for the FAAS team, and alongside this provides clinical supervision, consultation and input for children and adults affected by FASD. So I'm delighted to pass over to Sarah, and we're really looking forward to your presentation. Thank you.
Okay, thanks very much. I'm just going to share my screen, so you should be able to see the slides. So this is the first time, I think Jen's done a webinar before, so she's definitely better than me at it, but bear with me. So can you all see the slides? Okay, I'm just going to check the time. So. Okay, so thank you very much for giving Jen and I the opportunity to speak to a varied group. It feels like it's been a wee while since we've presented. It used to be at least a kind of twice weekly event for us, but with COVID, everything felt like it was grinding to a halt. So it's really good to get this opportunity to come and speak to people and see how we can keep some of the momentum that had been building, you know, to keep that going. So the hopes for this afternoon are on the slides, and really what we'll do is not spend too much time looking at the culture and context of alcohol use in Scotland, but certainly we'll take some time to look at it in pregnancy, outline the features of FASD and how, more importantly, how that impacts on the individual and their families, and then have a little bit of think about what else we really need to be doing going forward so that we can improve the diagnostic services and support services, but also, really importantly, the prevention aspects for FASD. A little bit of background about our team. There's lots of information there on the slide, but essentially Jen and I went on training in 2012. It was Scottish Government had arranged for a team from Manitoba to come over, and we were trained in the 4-digit code method of diagnosis. Following that, we piloted a small amount in Ayrshire, maybe 20 cases, and then submitted a bid to the Scottish Government to see whether we could really get a bit more time to develop our own experience, and really went on to assess or support assessment over 200 children in Ayrshire and elsewhere. Off the back of that, we got some additional funding, and we've got into kind of second phase where we're trying to disseminate some of that learning, and as part of that we were involved in diagnostic training for teams from all the different health boards in Scotland, and that was June of this year. We've also tried to use our time to work across different sectors. I think for context, I do this 1.5 days a week, and Jen up until recently was only 3 days a week, and we've got a full-time research assistant, but it has been tricky to try and meet the needs of all the training that's out there. We have got our initial pilot service evaluation, which the website's on there, so if you were interested in seeing all the mistakes we made and the recommendations that we then took from that, then you'd be able to get some additional information there. So I may well have covered part of that, but the other thing that we were involved in, and I can see colleagues who had joined the meeting who were also involved in developing the SARN guideline, and that was a piece of work that published January 2019. Yes, and that was the first Scottish and in fact UK guideline for diagnosis of children who were at risk of FASD. We as our team, in addition to kind of training and awareness raising and research, we also offer support and further training to third sector organisations and other health boards in Scotland. If clinicians want to make contact with us to discuss any cases, then we're here to provide that support. So, as I say, I'm speaking to an audience that's very well aware of the alcohol use within Scotland and the UK, but just to kind of focus down a little bit about alcohol use in pregnancy, it's embedded in our culture that alcohol, it's the only drug that people kind of give you a hard time for not taking, if that makes sense. People feel quite uncomfortable when you're not drinking, almost. And I think that the research that's on this slide, it shows that we know that when people do drink, they can have, on a quarter of occasions, they will drink to excess on their heaviest drinking day, but also that we also have more alcohol use per head in Scotland than we do in England. The alcohol use, the guideline in Scotland is no alcohol, no risk. So that really is to make sure that we are protecting pregnancies, and particularly unplanned pregnancies, from alcohol exposure. 46% of pregnancies in the UK are described as unplanned or ambivalent. So that was somebody who doesn't, isn't aware that they are pregnant and will continue their pre-pregnancy lifestyle until that pregnancy is recognised. And in 2017, there was an ONS survey that showed out of pregnant women, 11.3% of women who took part in that study had had a drink in the last week. Now, the guidelines changed in Scotland quite a while back, but UK came on board in 2016 to come in with a no alcohol, no risk guideline. Prior to that, there was a 1 or 2 units once, twice a week is not thought to cause harm. And I do feel that that's the one that people still will mention sometimes when we're doing training. It's definitely getting better. I've seen a big change over the last 5-6 years. But I always tell the story that when I was pregnant with my third, my dad was trying to offer me a glass of wine, and it was at Christmas, and it was, just have one. It's like, Dad, do you know what I do? I've spent the last 4 or 5 years going around, Scotland and UK, speaking about FASD, and it's really hard to change that culture and to make other people feel comfortable around you when you choose not to drink. I think we're making some headway with alcohol use in pregnancy, but I think there's still a fair way to go. And when I say a fair way to go, there was a study published by Popova a couple of years ago that showed that we were the 4th highest in the league table for people with drinking during pregnancy. A league table you don't really want to be at the top of. And you can see Ireland, Belarus, Denmark are higher than that. And I always think when I'm speaking to audiences, that's just like a number on a slide, but what we do have that, I'm going to flick forward to this slide, what we do have locally is in Glasgow at the Princess Royal Maternity Hospital. They did a study where they took meconium, which is like the first sticky sample that a baby passes from its bowel after it's born. And within that, they looked for something called a biomarker, which showed about alcohol ingestion during pregnancy. Now, that meconium is only made from 20 weeks onwards. So this result only really reflects from the kind of 2nd, 3rd trimester and misses the 1st trimester where you might not know you're drinking. And I would say that people are probably more at risk of continuing pre-pregnancy lifestyle at that point. However, from 20 weeks gestation, the biomarker showed that over 40% of newborn babies had that biomarker detected in their first stool sample. And of those, it was a significant quantity, 15% had it at what would equate to daily drinking or binge level drinking. So we know that we have the highest rate of drinking during pregnancy, or the 4th highest, and we know that that maps onto local data in terms of our biomarker study. And interestingly, there's no association between age, ethnicity, postcode, smoking status, birth weight, head circumference. This is something that is throughout society, and I think that probably goes back to Eric's comments at the beginning about where we anticipate this problem sitting, and it's not just within our most vulnerable communities. It is there, and it is represented in high numbers, but this can affect anybody from any background across the social spectrum. Part of the problem about FASD in Scotland is we've got no good prevalent studies, and very much the thing that always goes through my head is no data, no problem, no action. So if we don't know what we've got, we don't count, we don't diagnose it, therefore we don't know the numbers, therefore there's no problem and we don't need to do anything about it. And until we change the beginning part of that and we start diagnosing it and we start understanding what our numbers are, it's about trying to get the enthusiasm around improving things for prevention and for diagnosis and for support. In other countries, USA and Canada, it's estimated to be 5%, so what's that, 1 in 20, so over 1 child in every primary school class at least. The estimate in the SIGN guideline, I think, was put at kind of 3.25 to 5%, which we think is conservative, but that's the best evidence that we can work from. There was a really interesting study carried out in Bristol, which was a Millennium cohort study, and it really came up with a prevalence on a screening methodology of anywhere between 7 and 17%, which again kind of ties in with what we know from Glasgow and the biomarkers, that it's much more prevalent. Alcohol use is much more prevalent than we anticipate, and I think FASD is much more prevalent than the data that we work off. Based on the 3 to 5% rate for FASD, there would be approximately 165,000 to 275,000 individuals in Scotland affected as we sit here now. Now, for context, autism prevalence 1.2%, and there is national strategies and support and third sector and lots of, understandably and quite correctly, focus around supporting people with autism throughout the lifespan. And that's something that we would want to emulate in a proportional way for those people who are affected by FASD. It's a very expensive condition to not prevent and also to miss and misdiagnose. It's estimated to cost approximately 1.5 million across the lifespan of an individual. And that is predominantly from loss of kind of productivity, and also this doesn't take into account any care costs or criminal justice costs. So in real terms, it can be an underrepresentation of the true cost. And of course, that's just the cost in monetary terms. There's a cost to the individual, there's a cost to the family, and the kind of society at large. So when I go and look at a baby's notes, I can see very clearly normally what the mum has been on in terms of other medications, epilepsy medications, any other medications in pregnancy, any drugs, if she smoked. But people aren't particularly good at recording what alcohol was taken during pregnancy. And this statement, although it's from many years back, of all the substances of abuse, including cocaine, heroin and marijuana, it's felt that alcohol has the most global impact on the developing brain. We were recently in Vancouver, and what is coming out is the synthetic cannabinoids have a detrimental effect, and they've also got a synergistic detrimental effect when combined with alcohol. So that's definitely a kind of area of evolving research that's worth keeping in mind. I also feel a bit I shouldn't really be explaining this slide when Jen, the neuropsychologist, is here. But in my very simple terms, we know that alcohol is a teratogen. We know that it is harmful to brain cells, and you know that from your own experience of alcohol, from looking at the adult population, from people who use alcohol heavily. We know that it has a detrimental effect on the brain. What we also know is it has a detrimental effect on the developing brain, these very new cells that are trying to map the way through the brain for the processes and pathways that you'll need to be able to hold on to information and to be able to have those strong connections that we need. So if you look at as I look at it on the black boxes, if you look at the top box, you can see that at the bottom, neurons are born here, and they're supposed to kind of find their way out to the edges and make nice layers in the brain and make the pathways. The alcohol-exposed brain in the bottom box, you can see that those cells don't always make it, those white spots don't always make it to the outside, and it's much more kind of granular all the way up. People often think that FASD is only something that happens to women who are alcoholic, and it's really important to keep in mind that we would consider looking for FASD if there was no other explanation for difficulties. We would look at 3 or more exposures to binge level drinking during pregnancy. So that's only 6 or more units. And certainly within the context of unplanned pregnancies and the way that we drink now, I don't think it's not impossible to have drunk on 3 occasions before you find out you're pregnant. So it's not just something that affects women who are alcohol dependent. The other interesting thing is a point that's really important to make, particularly when we're speaking to a mixed audience, because we've all got our own experiences, we've all got children, we may have known we're pregnant, we might not know when we're pregnant. And what I don't want to do at the end of this is for people to go away and think, oh my goodness, I didn't know I was pregnant and I drank alcohol. The confusing thing about the messaging around alcohol in pregnancy is that prenatal alcohol exposure does not always equal FASD, and that's why it's a no alcohol, no risk message. There's lots of things that mitigate the risk for a fetus, and that can be dosage, timing, frequency, maternal age, placental function, your own genetics, baby's genetics. So we all know we metabolize alcohol in a different way, and I suppose the no alcohol, no risk message to me is a bit like don't drink and drive. We wouldn't all sit round a table and just because somebody thinks that they can handle alcohol better, they would drive home. We understand that it's no alcohol, no risk, and that's the point we're trying to get get across is that we can't predict who is going to have difficulties if they drink alcohol in pregnancy. Simply like driving your car home, if you've been drinking, doesn't mean you'll necessarily, hit a wall, write your car off, or wipe out another family, but you increase the risk of having an adverse outcome. And I suppose that's the way that we should consider it within the context of alcohol use. So what is FASD? Essentially, it is a neurodevelopmental condition which can affect many brain areas, and it really depends on what part of the brain is wiring up when the alcohol exposure happens. So you won't get exactly the same pattern in every individual. Equally, it's not always detectable at birth. I would say in the majority of cases, it's not detectable at birth, and it might only be something that becomes apparent in later life. Yes, you get the congenital abnormalities that you might be more familiar with, and people speak about the facial features, but they only happen in a minority, really, of individuals. But the common thread across all individuals who've been affected by FASD is usually difficulties with development, learning, or behaviour, and it's that kind of CNS or central nervous system impairment that makes things more challenging for them and more difficult in day-to-day life. And I think the difficulty from what Jen and I see is they're not understood. They look as if they should be able to do lots of different tasks, but really struggle to execute that. But I think they can get lost in a whole kind of complex situation, and sometimes the key point underlying it is often overlooked. It's a whole body diagnosis, and there's other people that give much better presentations than me regarding the whole body diagnosis, but we know that alcohol affects your immune system. It can affect developing organs. It's more than just your brain that's affected. So we'll show this one slide, and this is one slide of 55 that we're going to show you, and this is the only one with facial features, and I think that's important because it is such a small number that have the facial features. This in some ways is quite typical, but I would say it's quite an extreme philtrum and lip. It's very thin and very smooth, and actually the majority of these children I don't think look particularly dysmorphic. I think you can have a slightly indistinct philtrum and a slightly thin lip, and my kids, if they're not asleep, they don't look like they've got the best philtrums in the world or the best upper lip. And I know that I didn't drink at all during my pregnancies with those, and it's more of a familial look because my husband has it and my mother-in-law has it. And just because you've got somebody who's got a thin lip or a slightly smooth philtrum does not mean that they were exposed to alcohol antenatally, and it shouldn't be the only thing we look for when we're thinking of individuals who need our support because they have been exposed to alcohol prenatally. So you can't hear a FASD talk without seeing an iceberg. People would like to say, I don't know if can you see my cursor? Yes, people would like to say that we know about these ones here, and this is the kind of full spectrum fetal alcohol syndrome. I can tell you that I see kids that are 14, 15 years old that come in to see me and they have got full-blown fetal alcohol syndrome with all the physical features, and have never been picked up. So I would say we have a vast number of people out here who would sit above this waterline that we're still not identifying. It's felt that this kind of bulk of the iceberg under here would be individuals with FASD, which we now refer to as FASD with sentinel facial, sorry, the above bit is with sentinel facial features. And the facial features can attenuate with age, which makes it difficult when we're thinking about what approach we need to take across the lifespan. So I really like this slide, and I've been given permission to use it because I think even when I come across the people who doubt me the most, this does seem to get the point across. If you remember that the slide where we had the brain cells that climb out the outside and come back in again in the layers, then as you look at this, the colourful slide on the left-hand side, when you've not had any alcohol exposure, you've got lots of strong pathways that connect both sides of the brain. So you think about that, like the M8, big super information highway. If you've been alcohol exposed, those connections are much less in number and in kind of robustness. And I think people can think that these children aren't trying, but actually they've got less connections. They're trying so much harder to use, and they work so much harder than you and I would to achieve the same outcome, but it's not always recognised. The brains work harder, and the kind of black background slides, if you were doing a task, and so So let's say driving a car. When you first learn to drive a car, it's really hard and you use lots and lots of your brain, and then it gets easier and easier and easier. So these slides here are showing that in the control, they do a task and a bit of their brain lights up orange. If you've got, so ARND is what we call FASD, a bit more of your brain lights up, and depending on the degree of alcohol damage, you might be using your brain so much harder, but to get the same effort that the person who's not got an alcohol exposed brain would achieve. Then if you had serial pictures that go down the way, my brain would habituate, so I'd light up less and less and less, whereas the people who have been alcohol exposed continue to have to put in the same effort every time, and the learning is harder for them to embed, it's harder for them to achieve the same outcome in the same time frame as somebody who does not have an alcohol exposed brain. That doesn't mean they can't do it, it just means that you need extra time, extra patience, different ways of learning, and different support structures in order to help you achieve the same outcome. Often described by parents as 10-second children in a 1-second world. And I always, the information superhighway, when I'm speaking to other medics, I kind of say, it's a bit like when you go into your colleague's office, and instead of having the information superhighway, so you come in and I'm fairly organised, you ask me a question, I find the information, I fire it back at you. With less connections, it's a bit like the colleague that you go in and they have to scramble around their desk to find a little bit of the information that they're trying to find, or it's not been filed in quite the right order, so it can take more time to get that information back out. And that's got implications for life skills, for education, for when you are in the criminal justice system, how that delay then plays out in an interview context. So what you see is not always what you get. This is what we call an example profile. And what I tend to do is, if you cover, okay, just leave out the amber, red, and green, and you see that person and they look like they're 18 years old and they can chat away like an 18-year-old, they can read and they look 18. And actually, unless you dig down a little bit more into why that person's struggling, you might miss the fact that they've got the living skills that would be matched to kind of a primary 7. They might have the money and time concepts of a child in primary 4. They might have the social skills of somebody even younger, and the social and comprehensive maturity, which makes them incredibly vulnerable and difficult for other people to read in terms of their levels of difficulty. And when I look at a profile like that, if I ignore the fact that they look 18 and they can speak like they're 18 and they can read, it's essentially asking my young daughter and her friend to manage their own life, manage a tenancy, pay bills on time, keep themselves safe, lock doors, keep their own children safe. And I think we're asking an awful lot of individuals who require our support and understanding, but I don't think that we've got a society that's structured to recognise the deficits in the living skills that would allow these people to flourish and to perform the way that society currently expects them to. And this mismatch in expectations of what we expect of somebody who's an adult and what people who are unsupported may or may not manage to do on their own can lead to lots of difficulties. And we know that within the FASD community, lots of people who have a diagnosis of FASD may well have had a prior mental health diagnosis. So 94% have mental health diagnoses. We know that of that number, kind of quarter would have received inpatient care for mental illness. 80% find it difficult to hold down a job. 6% may have had difficulties with the law, over 12. And I've got another slide where I kind of look at how it all sets up. So if you struggle to attain in school, if you struggle to hold down a job, if you struggle to have friends, and if you fall through those gaps and you end up in unemployment, often that's where the mental health difficulties will start. That's when addiction issues may start. And so you can put these all in a circle, but there's a sliding scale. If we could get in early and get people understood and supported adequately, then we can ameliorate some of the difficulties that they then go on to face. And and that's got the better outcome for everybody involved. So leading on to the impact of unrecognised FASD, because we know that attainment, neurodevelopment, physical and mental health are all affected, and we know that they struggle not just to access the right support, I think it's the recognition of what support they require. They can end up in quite vulnerable situations. There was a study that came out of America that showed that the average lifespan for a person with, it was actually fetal alcohol syndrome, is 34 years of age, and that by far and large, the biggest cause of premature death was suicides, accidents, and poisoning by alcohol and illicit drugs. So kind of put down to misadventure. And when I go around neonatal units and trying to speak to people, if they thought they were discharging a baby from hospital, that for something that we're overlooking in that initial stage of life where we're not documenting any alcohol exposure, we are contributing to somebody having a considerably shortened lifespan if they are not picked up, understood, supported, or end up in a household where that happens automatically. So I think if I had a child who was affected, I know that within my house there is plenty of food, there's a routine, there's, you know, 2 loving, attentive parents, there is the opportunity to develop all these skills. We used to go to parks and do all the other things, we have to do that in the house now, but you're getting all the chances to affect that developing brain's neuroplasticity. And I do fear for a lot of the children who are born into more vulnerable backgrounds, there is a disruption in terms of caregivers, in terms of care settings, and that lack of understanding about the little person and what they need. And I do see that is where we sometimes get a bit of discrepancy between the vulnerable groups. And although we don't have, I mean, Jen and I could speak about this, you know, I don't know, Jen, weeks, months, but it's outside the scope of what we're speaking about today. But we know there is vulnerable populations, and they are within care experienced children, within the criminal justice system, within homeless communities, and individuals with substance misuse. And that's not to say that they're not out there in, you know, other families and other social demographic groups, but the needs are being met maybe in different ways. They're maybe more able to buffer kind of vulnerabilities or you know, financial difficulties. But these are the groups that we feel really do warrant additional research, additional scrutiny. Active case ascertainment would be amazing. And these are the things that we feel that need to be brought to people's attention in order to help move things forward, both in terms of policy and understanding. I'm going to check my phone now. I know I should have done it earlier. I'm a wee bit over my 25 minutes, but not too bad. So I'm going to hand over to Jen just now, who will speak a little bit more about the implications of FASD on a day-to-day basis, now that I've given you a bit of the background context. So I hope that was clear enough, and I will hand over to Jen.
I'm hoping this works okay. Can you see my slides all right? Okay, great. So I'm going to give you an overview about how my FASD be identified, and to think a little bit about the brain difficulties that people experience. Some of these you might recognise from FASD training that you might have had, or from other training, but certainly it's just to give you that overview, and also to give you an insight into some of the milestones within our team from a strategy point of view, and from a One for Scotland point of view. So those slides will follow, and I'll hopefully manage that in about 20 minutes, if that's okay. So to give you an overview of our assessment, I'm going to take you through these brain domains that are also explained more fully within our evaluation document that's available online. So it's really just a whistle-stop tour of the sorts of difficulties that people might have. And to point out, I suppose, that people don't necessarily have a global or intellectual disability. People might not have an IQ below 70, but there certainly will be 3 or more areas of that brain picture that there will have, the individual will have significant difficulties. And those profiles are very variable from individual to individual. So it's not an easy diagnosis to reach. It's more of a diagnosis by exclusion. As Sarah said, we'd look to exclude genetic or other reasons for this being the case. But when you have a significant alcohol history, evidence, and you have this cluster of brain difficulties that are otherwise unexplained, then we really do need to think about FASD more often. As Sarah said, one of the issues that we might find, but they're not found until maybe later on, or until there's formal testing, is difficulties in communication. So although in that brain profile example that you saw before, the individual may be able to chat like a 20-year-old or an 18-year-old, when you scratch the surface and formal assessment is done on these individuals, what you find is that they do actually have significant issues with expressive and receptive language, being able to fully understand instructions, and being able to, the speech and language therapists that we meet and who do these assessments, they describe it like there's lots of things being said, but there's very little content. And although people can maybe parrot back or repeat back things that they have heard and have listened to, the actual comprehension and level of understanding is far, far less. So we find people, and Moira does an excellent lecture of vulnerability in the criminal justice system, where people are parroting back and saying, this is what I've heard, do you understand? And people say yes, they might acquiesce to that question, but when you really unpick what's been understood, very little has been taken in and retained, and that has massive implications for giving evidence, for example, or statements as a witness or otherwise in the criminal justice system. So formal testing is often very illuminating, but the communication difficulties people have might not be immediately apparent. Certainly in our clinic, we were meeting children and thinking they didn't need to see the speech and language therapist on face, but after assessment, finding that young people were having, their language issues were in the disability range. Also in the sensory and motor system in the brain, individuals may, but not always, it depends again on that timing and dosage and frequency of drinking, they may have issues with fine motor and or gross motor skills, struggling with coordination of tasks. They might have been delayed in walking, not being able to ride a bike, or might often trip and fall. Some people just don't have those difficulties. It's very variable, but one of the things that we're finding a lot, and that is also something that's been unidentified, are issues with sensory processing. People may have extra sensitivities. You might have learned about that from thinking about individuals on the autism spectrum, but also in this population, a lot of the children are undersensitive to pain stimuli or temperature, and don't quite register when they might need to seek help for a sore arm. We've had children who have went days without realising that they've actually fractured their arm in an extreme case. So these are children who should be seen by an occupational therapist and have these things explored where needed. An important point I hope to make to people watching today, and I'm not sure what everyone's backgrounds are, but if you're meeting or working with people who have not got an intellectual disability, but you can see people are just not managing day to day, and off they go maybe perhaps for a cognitive assessment, something to find that we found out about FASD, and this is backed up in the literature as well, is that individuals don't necessarily come in as having an intellectual disability or IQ below 70 on this screening assessment. They might have a low average, in some cases, and a perfectly average IQ based on these tests. And sometimes clinicians, and certainly when I used to work in CAMS, if that's the results that we get, we wouldn't do any further testing. For individuals with FASD, what happens is when you scratch the surface of the brain areas, those areas are significantly in the learning disability range. It's just not that globally that is the case, and that's why individuals often fall between services. They're not somebody on face or on paper or by the numbers who would look to be able to get support from a learning disability team, and yet day-to-day function, and when we measure that, and I'll go on to speak about that in a second, those adaptive day-to-day skills and safety, health and safety, cooking, running a house, are in the learning disability range. So that was just an important point that I wanted to point out to everybody about this population. And also, although a lot of these children might have a diagnosis already of ADHD, or indeed adults, when you test attention formally in a quiet environment, these kids can do quite well. Yet when they're in the normal day-to-day environments of school and home, where things aren't quiet, like a clinic room, there is huge issues with focus and distractibility and attention. So that can present itself and be complex for teams like CAMS or paediatrics or CMHTs to investigate. So on the one hand, you've got somebody who's not functioning out in the real world. In the clinic, they might not look like that. And so these things do need measured and investigated. But a lot of our children had a diagnosis of FASD, that did get a diagnosis of FASD, also had a diagnosis of ADHD, but didn't necessarily find any benefit from the medication that they had been taking. Individuals, on top of having some degree of attention problem, might find that there are issues with language, all interact to create memory problems. And sometimes the memory banks, if you like, the filing cabinets, aren't working either. So memory can be poor, it can be okay in some, again, it's variable, but retaining day-to-day instructions and information, sequencing events from the past and thinking about what's to happen in the future can be a challenge. And sometimes we find these children have been asked to use visual materials in school as a learning aid, and then when we assess their memory, their visual memory is actually the poorest. So it's about understanding the individual profile for that child and for the family, so that we're able to tailor the memory adaptations and aids to suit them. The sort of blanket approaches don't tend to work for these children, particularly if we don't understand the nuances of their own brain profile. So it's very much like a brain injury, and working in a brain injury population, which I have before, and not one size will fit all in terms of strategies. So we really do need to look at the profile so that we can help teachers and families to understand what individuals need. And I also think about Moira's lecture about criminal justice system, thinking about what lawyers and police need to understand about these adults in terms of their ability to retain and to recall and think about what they're saying in that formal environment. A really important area that can be a huge difficulty in FASD, in fact I think it's probably the most common that we've found and in the literature as well, is executive function. So the sort of frontal lobes of the brain, the chief executive of the brain company, if you like, they have difficulties in sequencing events. Cause and effect is an abstract concept in a way, and learning from mistakes relies on those abilities. So hence why people tend to have a high rate of recidivism, making the same mistake again, coming in front of the judge with the same pattern of behaviours. And planning and organising, seeing the consequences, and as Sarah said before, managing time and money is a difficulty related to that brain area. Controlling impulses and emotional regulation is also very much tapped into those frontal lobes. And so these individuals may seem very chaotic, unable to keep appointments, unable to reflect and have insight and awareness, particularly in the moment, but they may demonstrate that afterwards when they're in a quiet space. So again, you can see the links to, perhaps running a tenancy, the criminal justice system, being able to function as society expects. Is a real difficulty, and it's not a case of I won't, it's a case of sometimes people can't, and they require almost an external brain to support them with these abilities. And because of all the aforementioned areas, adaptive living is usually really out of kilter to what is measured on cognition. So people are often baffled, but this person's got an IQ of 89, why are they not able to do X, Y, and Z? Well, it's because of those multiple brain areas that are significantly struggling, not able to work in harmony with each other, and that's why. So the daily living skills could be half of somebody's chronological age. It could be a little bit more than that perhaps, but generally as people get older, the difference between where they ought to be and the trajectory with their peers tends to widen as the expectations of life grow. Unfortunately, the brain and neuronal connections that are needed to manage those demands don't grow in sync, and so budgeting money and understanding rules of safety is just not there. So I hope that you know, people are maybe thinking about folk that they've worked with or known in the past where there hasn't been that ready, easy explanation of difficulties, and where you have got exposure to alcohol in a cluster of those areas of difficulty, then FASD might be what we're talking about. And what we often see in our children's histories or in adult histories are struggles to attend mainstream. There's a high rate of school exclusions, behavioural difficulties, although some teachers will then talk about strengths in maybe maths or in practical subjects, or perhaps in English. It could be that literacy is actually a strength. And that's why sometimes these children are chronically misunderstood, because they do well for Mrs. Smith and Mr. Jones, but not for these other teachers. It seems to be put down to volition rather than brain function. And that's why we do a lot of training in schools to help people understand about FASD. And I suppose just quickly moving on to the other assessments that we do, mental health and risk is something that we must look at in FASD because of the chronic issues, managing expectations at home and at school, and having that brain fatigue that Sarah talked about before, and a lot of those issues being largely unrecognised and unsupported. We found that a third of our young people required a mental health assessment that I would normally have undertaken in CAMHS, and in fact a lot of the children needed to be referred over to CAMHS. And even though this was in an under 12s sample of just under 30 children, sadly a third of the children on their screening assessments for mood said that they thought about suicide but wouldn't do it. So I'm just going to repeat, this is under 12s. And when I'm checking for understanding, because I'm aware that these children might not understand what that means, these kids understood what it meant to not want to be here and wanting to die, and were you know, using phrases like I can't cope, I just don't want to be here anymore, and one boy saying I just don't fit this world. And children were actively trying to end their lives using ligatures and things like that in this population. So when I think about these children as adults and thinking about our policies about suicidality and mental health, and we're not maybe thinking about this in that context, then we are missing a huge part of the jigsaw puzzle with a prospective prevalence rate in excess of 5%. You probably wouldn't be surprised that a lot of the children, given the higher prevalence of being care experienced, will have significant numbers of ACEs, trauma, neglect and attachment issues. They've been in services maybe up to 4 years, and we also have the current status quo that although things are improving in child services, there is no current adult diagnostic pathways for recognising FASD. And so people can tend as adults to be understood within that sort of trauma framework, which might be right and appropriate, but what they're lacking is that neurodevelopmental lens and layer to what is a very complex presentation. And I've been alongside adults who are receiving mental health input in the way of talking therapies or other therapies that are quite complex, and because somebody's able to chat away, but they're not maybe measuring the memory of these folks, the therapies that they're accessing are just not going to be efficacious. So more detail about this, I'm sorry if I've went on a bit longer than I'd hoped to there, is in our evaluation. And our key learning is detailed in there, and I've just taken some snapshots of what we learned about prevention. As Sarah said, the no alcohol, no risk during pregnancy message is not widely understood. I think people might maybe know that you're not meant to drink in pregnancy, but the rationale as to why isn't there, and without that rationale you're not going to be able to affect behaviour change for health behaviours. We need to increase that education and screening of people perhaps who are planning to be pregnant, who are pregnant. There needs to be more training on alcohol brief interventions and recording of alcohol use in pregnancy. And in our clinical experience, we found that it was hard to get documented evidence of alcohol use from a note that had been taken by a midwife during a pregnancy. And even for care experienced children, it was sometimes really difficult. So recording is as important as training and education, but that education needs to span schools, young people, sexual health and professional training courses. And all of this is in its infancy in Scotland, to be honest. And we do need a lot of support with that. And that will all flow into prevention and also identification, because we'll have better recording. And with our work, we're hoping that more services will be able to offer FASD assessments, and that should be across the lifespan, as I said. I hope that we've been able to argue that formal diagnosis is beneficial, not only to receive the right supports on a practical basis, but it's about understanding that profile of strengths, but alongside the difficulties that need supporting to manage, to attain, to keep attainancy, to be able to have the best outcomes in life. And that support extending to family as well as the individuals affected, and the crucial multi-layered approach of looking at neurodevelopmental, attachment, trauma, mental health, and not forgetting that neurodevelopmental bit. And often because of all those factors, we're needing intervention that is tailored, multi-agency, intersectorial, and lends support and understanding to the family. So training is massively needed within the NHS, social care, third sector and education. But in order to further that, I feel we really do need a stronger evidence base on the specific scope and impact in Scotland. And to help people feel that we're not starting from scratch, the team, as Sarah said, we've been around for 6 years now. We've done quite a lot of work in regards to prevention. We've got training packs to improve that alcohol recording, to improve the ABIs. We've also scoped out best practice campaigns for reducing alcohol in pregnancy. And I'd like to raise awareness of Drymester, a Greater Manchester project to participants as something to look at. And they're on Twitter and online. It's been a fantastic campaign about staying alcohol free, and for that to be a whole societal approach. We've also got a whole load of resources that you can see there, spanning parent carer education and for midwifery. And all of that is on our website as well. Alongside colleagues, we've developed a SIGN guideline. As you know, that was launched January last year. And alongside that, worked with colleagues in government, Jonathan Sher and Chris Steer have done a lot of work regarding 4 new e-learning modules that are coming out. We've been able to join that piece of work, and we're glad to see that it's progressing towards being on a NES platform. In addition, we've also got some training packages that we're hoping to put online that can be accessed by people in capacity to do that training. Was being broadened within Ayrshire using our train-the-trainer model, so that could be cascaded perhaps if those materials can go national. We've also been doing diagnostic training, and Chris Steer chaired a professionals forum that was a sort of twice yearly group of us that got together, and people would be very welcome to join that. That's something we hope will continue in some form or other. Chris did a wonderful job of getting that off the ground. So people might be aware of what's already in the alcohol framework 2018 regarding FASD. That's just a brief summary that pretty much maps onto the work that you've heard of today. But something that hasn't been until recently is our membership of the Children and Young People's Mental Health Taskforce. I've been on the neurodevelopmental strand of that for a couple of years, and Sarah's also joined. And within that, we're really pleased to say that FASD is to be considered alongside all other neurodevelopmental conditions like autism, ADHD, in regards to thinking about equity and capacity in children's services for neurodevelopmental work. Our project has led to a project initiation document that's circulating in government and will go for approval, and it's looking for us to develop a service specification for neurodevelopmental services. This is going to be out with CAMS. You don't need to have a mental health problem to be able to access this. It might also sit out with paediatrics and be for children, including those affected by fetal alcohol spectrum disorder. So where there was very much a difficulty with access and diagnosis, I'm really hoping that in the medium to long term that will be a thing of the past, that there's going to be a no wrong door approach for children and affected families. And taken straight from that document is this text. It's a wordy slide, but you can read it at your leisure, that there's going to be particular attention given to certain groups, those in care and at risk of going into care, and I've highlighted also that there's going to be attention to those who've been exposed to drugs and alcohol in utero, and those were quite amazing words for me to read. When I saw it in black and white, I did pretty much squeal with delight to see that these children are going to be recognised in an equal way. And our vision for identification has long been under that umbrella, alongside all those complicating factors, is that FASD is considered within our NHS, within mainstream services, not in specialist clinics that there's hardly any of, and that we've also got a responsive third sector, which we now have in the form of FASD Hub Scotland, alongside other third sector organisations. And if we all did something, we would expect that 1.5 million per affected individual to be something that we don't have to see. And incidentally, I thought it was quite clever that Drymester campaign limited their budget to that exact number. So if their whole campaign prevented one case of FASD, it paid for itself. We must promote the no alcohol, no risk message and raise awareness of why that is. And we need urgently prevalence data and case ascertainment studies across a whole raft of populations, including the general one. Implementation support is also needing to continue for the new SIN guideline, and the government and ourselves, we want children to grow up in Scotland and it be a wonderful place, but at this current time, 1 in 7 of our children before they come out of the womb are at a significant risk of disadvantage. So I feel like within our attainment policies, within our mental health and wellbeing policies, we really need to be thinking about this. And that's a summary. I know some people didn't manage to come for the beginning of the presentation, but I've managed to hopefully capture some of the main points here about prevalence and impact for Scotland if we don't do something together. And I'm really glad that we've been able to come to this forum and think about what that could be, what we can do together to prevent and support people affected by FASD.
Thank you very much, Jen. Thank you very much, Sarah. Just to say that you've covered an incredible range there, but we do have plenty of time, I think, for discussion and questions, which I think people are dying to get in on. I've got one question that's been put through already, asking about what the role of the primary care team is in FASD across prevention, diagnosis and ongoing care. And maybe if you could tell us what you can about your local area, but also what you think is the case across Scotland, and if you know anything more widely than that.
I think it's very difficult in terms of what the primary care input is. I think it very much depends on what the age of the child is that's presenting. In terms of health visiting, if we think about it as a kind of life course approach, if the health visitor is aware that a child has had significant amounts of alcohol exposure antenatally, that is something that we would hope would be included in any referrals into a child development centre, so that information isn't lost and doesn't have to be kind of dug out. I always think I'm part medic, part detective, and sometimes find that information is really tricky. I would say over the last, what do you reckon, Jen, 3-4 years, we've seen a huge difference in the referral that we're getting in from NHS Ayrshire and Arran primary care. So it often has the alcohol history in it now, which I would much prefer to know rather than whether they were born by SVD or caesarean section. That has very little impact on your overall attainment in life, but we're so used to putting a set flow of information in a referral. It's just about changing that culture and that context, but what information is actually really helpful for a clinician. I think GPs play a crucial role in knowing families and knowing perhaps what isn't documented, and being able to have that relationship with families that is supportive and non-judgmental and perhaps able to support families and birth families if they're on a difficult kind of journey with that. Other than that, I think it's probably about them knowing where to signpost families to, both for support and for diagnosis if that's something that they want to seek. I think we've probably got a bit of a cultural change within health visiting. I'm not sure, we've probably not done as much work with GPs as we could or should have, but certainly from a health visitor point of view and that kind of first contact that babies have following hospital discharge, I think we have probably done quite a bit of work. We've had a good uptake of our FASD Raising Awareness programme, which is there's usually about 10 or 12 dates throughout the year and they're always full. So we've kind of got that ongoing learning opportunity for any new staff as well.
I was just going to add, just from the prevention point of view, I think that there can't be too many people involved in giving good timely information, and I know that there's a lot of good work happening with the preconceptual framework around people planning pregnancies and both men and women thinking about their lifestyle as they're thinking about starting a family, for sexual health clinics to think about giving education within that forum as well. Just any opportunity really for universal health and primary care colleagues to know about FASD, because we did a professionals knowledge survey of just people working in Ayrshire's Health and Social Care Partnership, and very few people had an awareness of FASD and what that really meant and what contributed to that. And there was a lot of myths that were going around about FASD and the cause. And so I think just education and increasing capacity for training in primary care is a huge milestone to be met at the minute.
Sorry, Eric, you need to turn your microphone on.
Yes, I got it. I'm giving everyone else instructions and I'm not following them myself. Can I ask people to raise their electronic hand, so you can go into your participants on the bottom of your screen and raise your hand if you want to raise some points. Can I ask about this thing about because when you were describing the functions are affected. A lot of the things that you're saying about children, kind of not planning and not thinking about cause and effect, would seem to be things that would be normal in children who didn't have any difficulties. But later on, that would be when you would begin to notice. So maybe if you're still not able to plan and still not able to manage money when you're a teenager and a young adult, that's when those kind of things would be picked up. It sounded like you're saying there's a complete mismatch between well, there was a lack of services, and I think you said there's no adult diagnostic framework, and does that mean that there's no services then for adults as well? Excuse me if my question's a bit stupid. I'm not a clinician, so maybe my
no, it's not at all. And I think what we definitely have seen is peaks in referral ages. So you may get a child, or I may get a child referred to me who's a baby who has small stature, small head, and facial features, known from a mum who's been supported perhaps by the safeguarding team, and there's a clear relationship that needs developed, and an approach taken to reaching a diagnosis. So that's the kind of extreme newborn age. But following from that, we tend to get a bit of a peak around about when kids are going into P1, where people start to think, oh, there feels like there's maybe something else going on here. Then there's a further peak in referrals about 9, 10, when they're heading into high school. And then it's when the environmental supports drop and you don't have that best friend that's been with you through primary school that you can kind of copy. Then we tend to get the crisis phone calls when kids are about 16, 17, 18 and about to bomb out of school and services. And I think that it is a very much a indication of when more is expected of them and they're not being able to meet the kind of societal expectations. In terms of adult services, I think we're really limited. Locally within Ayrshire, we may have supported adult clinicians through a handful of cases, but there's no wider strategy to look at. I mean, these people, they grow up and they go on to have their own families, and I think it's also really important that, as we're saying, that as they grow up, the gap widens, but then they do continue to gain skills. It's not as if it's the end of the road and there's no further learning. It's just that things take longer, and Moira, who's on the call, is much more able probably to speak about how the adults, particularly North America, are now kind of speaking out about their experience of FASD and how it's affected them growing up and how they then perform in their kind of third and fourth decade. But in terms of adult services, Jen, is there anything you want to add? Just you're more lifespan trained than I am.
In my experience, the clinicians that I've worked with in adult services have maybe been able to assess for autism, perhaps ADHD and learning disability, but FASD seems to be something very new, even though this is a condition that was first, written about in the 60s and prior to that, actually. So it's I think stigma has had a big impact on why perhaps people don't feel confident enough to go there and think about alcohol exposure in pregnancy. People seem to feel very uncomfortable about it, but by and large people just say that they don't have the skills to assess for FASD in adult services, and certainly it is true that neurodevelopmental assessment capacity is much less in adult services than it is in child. And you're right, things like executive function are absolutely something that you can measure really well in adults. In teenagers and in older sort of primary school age children, you can start measuring executive function from about 8 years old, and you can see where kids are going to be struggling and might not develop the same skills. But in an adult service, it would be very quick and ideal to be able to assess exec function. You can do it in about 40 minutes. There's also a parent, carer, support person questionnaire that people can fill in that goes along with the standardised assessment, and then to get an adaptive skills assessment doesn't take too much time, maybe an hour or two, and that would give you a really good overview of someone's exec function and adaptive function. That's two of the brain areas that you would need. So it is possible for adult services to do, but it's just going to need some training and support to get adult services catching up on child.
And there's the capacity issue.
So that's what could be in place, but which isn't in place at the moment. I do want to come to Moira, if you don't mind, Moira, in a minute. So I want to ask you something, because you mentioned something about ADHD and medication for ADHD not being helpful. Excuse me, again, if this is a stupid question, is there medication for FASD that's useful, or is it a completely non-medical interventions that are going to be useful? I mean, obviously that's contested for ADHD as well, and there's a problem with that condition being over-medicalised as well.
Yeah, I think that's a good question for me and Sarah to both answer. So coming from this sort of neuropsychology perspective, what we're finding is a lot of those kids might very much look like they have ADHD. They're distractible, they're impulsive, they're maybe overactive. And so they're scoring really highly on screening assessments for ADHD. Once you have the child's environment suiting their sensory needs and their motor difficulties are adapted and taken care of, what we find is that the ADHD symptoms, if you like, lessen massively. So what might look like ADHD on face may not be ADHD, but in some cases the kids can also have ADHD and FASD. It's never one or t'other, it's not black and white. But because of the structural brain differences that there are in kids with FASD, it's not just the biochemistry that the medication is working on. It's often a diagnosis of ADHD that's given with medication, but that isn't answering the whole question. And certainly in a lot of our children, some kids benefited from the meds, a lot of kids weren't, and simply were getting taken back off of the medication because it wasn't having any efficacy. But there are changes to, and this is where Sarah should hopefully come in, about what medications might be recommended for FASD and ADHD versus ADHD alone.
So there is an algorithm that looks at what ADHD medications would be perhaps work better within the subgroup with FASD. I'm kind of at the beginning of my ADHD prescribing career, simply because this is something that was usually done by CAM psychiatry, but now we have a national shortage of CAM psychiatrists. We're trying to plug the gaps in various ways. I think I would still be more comfortable following NICE guidelines, just because I would like to follow something that's more structured. But I am aware that there's other ways out there, and I think they kind of feel like dexamphetamine may be a better match for people who also have FASD. But it's one of these things that I think, by and large, the biggest thing that I think we see making a difference to families is understanding that a young person is really trying, and it's not that they're trying to be challenging or belligerent or difficult, and it's that even just having the diagnosis and the understanding and the profile is the therapeutic aspect of what we've done. Occasionally, I can use melatonin if sleep is chronically, problematic, and that's something we see a huge amount of with children and young people who have FASD. So I think that it still boils down to, as an individual, people need to be understood. They need other people around them to understand them and to scaffold, like we all do. I'm good at some things, my husband's better at others, and it's having somebody who complements your skills or can help you when you find things a wee bit difficult. And I think that still probably is the mainstay of what we think helps the most, rather than a medication.
Thank you. So I'm going to invite Moira to kind of come in, and then after that, Chris, I can see that you're looking to come in after Moira as well.
Thanks, Eric. Thanks, Jen and Sarah. That was, as usual, wonderful.
Moira, do you want to say who you are?
I'm Moira Plant. Sorry, I'm a long-term interest in FASD, alcohol researcher. Retired, but that hasn't quite worked out as well as I planned. And I'm interested. Your misunderstanding, I think, one of the good examples of that to me was a young boy that I spoke with in Canada, who had been having trouble attending counselling sessions, and his mother had given him a digital clock, a digital watch to help, and told him that when it got to 9:45, he had to get up and go to the session. And he still didn't attend the sessions. And when his mum asked him what it was, he said, well, I looked at the watch and it was 9:40. And then I looked at the watch and it was 9:50, but it never got to 9:45. And the problem was, everyone thought that he was being difficult, when actually he wasn't. It had never got to 9:45 on his digital watch. And I think that's an example of just how complex this is. And I think that Sarah's absolutely right, that this is about understanding these young people. It's much more important for them. I think medication has its place, of course it has, it always has. But I think in general, this is about listening to people and about helping them. And I think one of the issues, and a very sad one, is this high suicide rate, accidental or otherwise, at an early age. And part of that for me is this struggle to have friends, is this incredible loneliness these children feel. That they will meet a group of friends, they seem to be getting on well, and then somehow or other the other people in the group realize that this person's a bit different, and they lose these friends. And they have terrible problems with depression, terrible problems with loneliness. They have problems with ear infections that can lead to deafness that doesn't get picked up. And one of my friends in the States went with his wife. He had full-blown FAS, went with his wife when she was pregnant, and they were asking if the couple had any trouble. He said that he had FASD, and the doctor wrote down, well, yes, but you seem okay. I'll just write down on the notes that you're not violent, so it's safe for people to come into the room when you're here. So the problems these children have, the problems these young adults have, is enormous. And I think for me, listening is still one of the most important things we can do for them. One other thing I would say, and that is, I think that what's happening in Scotland is amazing. I think thanks to Jen and Sarah and Chris and Maggie and a number of other people, we have moved in Scotland in a way that has not happened in many other countries. I know Canada is very impressed with what we're doing. The one thing I would add to it is I think we need to have a strand to support the professionals who work with these young people. These children are needy, they are often extremely difficult to understand, and they need help with that. And the professionals hear terrible stories from these children and from their families. And I think they need help and support to work with that, because once they make a connection with the families, hopefully that connection can stay for a while. If professionals get overwhelmed, and there's a real risk of that, if professionals get overwhelmed, then we're going to lose those professionals, and we can't afford to at this point.
Moira, can I just ask you, is continuity of having the same workers working with these people over time, is that important?
It can be very helpful, because the children, as they grow up and become younger people and young adults, feel they have a friend, feel they have someone who understands them and accepts them. And if something happens, that person hopefully will say, well, okay, what was your side of the story? And the young person feels they're being supported. Trouble is, of course, that our services don't work that way. Once they get past the age of whatever, 18, they go into different services, and often that link is lost.
Thank you. Chris. Sorry.
Thanks, Eric. An opportunity just to pay tribute to Sarah and Jen, and thanks to Moira and other folk for their support over 10 years now or more in this field. Sarah and Jen have really been in the van and had done so much to advance the cause, so to speak. There are just one or two minor points. I won't follow up on the ADHD asides you made, Eric. We can deal with that later over half a pint of pale ale, perhaps. But the question I suppose I'd like to pose to colleagues within SHAAP, and remembering my backgrounds in sort of paediatric neurology and paediatrics in 5, and a period of advice to Scottish Government and lots of unfinished business around FASD. You touched on something very important, and that is, what about following the so-called age of transition and moving on to adulthood, and the huge number of undiagnosed young people with FASD who carry with them a lot of baggage and complications and need for assessment by adult services, and as you've intimated, a huge gap there. In Canada, and feedback from the team there in Manitoba addressing what can be done about adult services, they've had huge challenges getting adult psychiatry and psychology to engage and undertake assessments. And I think that what they've got round to is specially trained general practitioners to undertake those sorts of assessments. Also, of course, they've got special courts for young people with FASD, and they've got special resources for sifting out and screening young people who get in cahoots with the criminal justice service to get a diagnosis made and to give them the support that they need but don't have. So I suppose there's a question from my distinguished colleagues within SHAAP who have got long careers in psychiatry. Do they have any insights or observations they may wish to share about how that gap may be filled? We have had lots of challenges training paediatricians over time, but I think we're getting there, and Jan and Sarah are continuing that. But any observations or help from Peter or Bruce or colleagues with psychiatry persuasion, please?
Okay, shall I ask Peter, are you happy to come in?
Happy to do that.
Yeah, I've unmuted you, yeah.
Okay, yeah. Well, firstly, Chris, we have one specialist alcohol NHS treatment service in Scotland now.
Peter, is it possible you can be louder? But I can't really hear you, I don't know.
Can you hear me? Is that better? Is that better?
Yes, slightly, yeah.
Can you hear me? Yeah. Okay. Yeah. I think two main points to make to Chris's comments there. Firstly, that of course, there's a major capacity issue in addiction services. We have one specialist consultant psychiatrist who really majors in alcohol problems in Scotland now. The rest are mainly involved in combined services where there's a lot of pressures on other drugs now.
Peter, if you can get nearer to the microphone, it would be helpful.
Can you hear me? Can you hear me?
It's quite faint, but I don't know how other people are. Maybe just keep it as close as you can, maybe.
Okay, I will do. Right. Okay, is that okay? Is that okay, Eric?
I think it's as good as it's going to be. Yeah.
Okay. Right. I was hoping you would say yes, but anyway, so that, I think the first point is capacity in alcohol services. And I think even if we had capacity, actually the points that Jen made earlier about the need for a neurodevelopmental service is exactly the same point that we made in relation to alcohol-related brain damage at the other end of the age spectrum. That actually what we need are good neurodevelopmental services that will assess and put together care plans for people, actually irrespective of the etiology. So at the other end of the age spectrum, we'll have people who've been heavy drinkers, who have a history of head injury, who have a history of cerebrovascular disease, who get an alcohol-related brain damage diagnosis that excludes them from neurodevelopmental services. So I think that in answer to Chris's question, it was a recommendation that was made about probably 12 years ago now in a comorbidity report, that I think actually what we need are much better neurodevelopmental services for adults. There are reasonable services for people with brain injury for kind of historical reasons that grew out of neurosurgery services. But for people who have neurodevelopmental problems that are not judged to be primarily due to traumatic brain injury, services are poor. And so I think the same thing applies to FASD as applies to a whole range of neurodevelopmental issues. So I hope you heard that.
Okay, thank you. Is there anyone else who wants to come in? Bruce, are you signalling to come in, or are you just wait? Okay, yeah.
You hear me? I'll come in. Can you hear me?
We can hear you, yeah.
I'm watching it all on an iPhone. It's a bit difficult, but it's actually been fine, and two excellent presentations. I've been thinking about what.
Bruce, you would say who you are for people who may not know.
Sorry. Yes, I'm former chairman of SHAAP, and I'm a psychiatrist now retired who's worked for most of my career in addiction services, particularly alcohol services. And I was agreeing really with what Peter's just been saying, and thinking about this. Is there anything distinctive about the treatment of people who have these problems in adult life? And I think it probably means they need to be helped by the neuropsychological services, which of course are very rudimentary in Scotland and in most other countries. I don't think they need a special service for that is built around the alcohol services, but rather they need help from people who are skilled in the psychological management of people with a degree of psychological impairment. And one of the things I've wondered about is how distinctive is that impairment? Is it a distinctive entity, or is it really very similar to many other causes of psychological, neuropsychological problems in later life? But I think we couldn't add it to the psychiatric addiction services, and I'd agree with Peter there.
Yeah, I don't know whether it's useful to say, thinking about my time working in adult brain injury and working in FASD, I can see there are overlaps, and I suppose if we're able to have these individuals accessing a good neurodevelopmental assessment, and if we don't have any reason to suspect that it's came from an in utero place and might have been something from a head injury sustained later, I suppose you can only think about etiology as far as good evidence of history goes. But you're right, I think about thinking about the profile of difficulties for the person is often the most useful thing to do. People just understanding that there are communication or memory or exec function issues, and being able to think in a multidisciplinary way about a care plan is first and foremost the most important thing. And I really think that people, perhaps in adult services, think that to provide that would be far more work than it really is. I was able to do FASD assessments in probably the same amount of time as an ASD assessment, probably the same amount of time as a dementia assessment or acquired brain injury assessment. It's just about doing what's right for that individual, and I agree with what Bruce says about capacity to do that. But I'm an eternal optimist. I don't think it would be beyond the scope of disciplines to come together with their tool bag, what they already do. It's how it all comes together and fits like a jigsaw, more than needing to equip individual professionals with new skills. They just need to be configured in a different way and do something in probably what will be a more efficient way and take less time. So it's just about asking people to do things differently rather than do more. So I completely agree with what Bruce says, and echoing the point that Chris said earlier as well. I hope that's helpful.
Jen, can I keep on asking stupid questions probably? So if that is so blooming obvious as it seems, where are we in relation to that at the moment? And if we're not where we should be, why are we not where we should be?
So being on the task force, I think saved my own mental health. I think getting to a place where people had the view that we could do this for all children, that they didn't need to get a mental health difficulty and be in distress to access a neurodevelopmental assessment was wonderful. And to look at a service specification for neurodevelopmental up to the age of 18 has not been rocket science. It is just a matter of getting the right people in the room, and yeah, it's just a reconfiguration. And I really think that if we get the Children and Young People's Task Force neurodevelopmental pathway right, I feel that it wouldn't take too much of a stretch to make that go into an adult place. A lot of these adults access much the same assessment as the children, they just do the adult version of the test. So this is something that maybe could be piloted in a Children and Young People's realm. And then there would maybe be people in adult services that might want a bit more in the way of upskilling, but I know that there's interested people out there. It's just getting like NHS Education for Scotland and the professional training courses and the competencies that are put to those to be in sync, and allowing CPD to be supportive of this new way of thinking, that we're not looking at ADHD pathways and ASD pathways and disorder specific paradigms. It's about looking at things in a more holistic way, working together in a different way. But I don't think this is impossible to do, and I know that because we've already done it in parts of Scotland, and people are already doing it even in adult services, small patches, but they're showing it's possible. So where there's a will, there is a way, is always what I say.
Sorry to come back to you, Moira. I do know that you're looking to come in as well. I want to ask you the question again, if you don't mind, about, because it's almost like you told us what is needed. I still don't know, but have we got the right people? We need to get the right people in the room. It's not that difficult, but are they in the room at the moment? And if not, why are they not? Sarah, can you answer maybe?
So Jen's eternal optimist, and I bring I bring bleakness usually, and then we kind of oscillate between ourselves. But I think that I share Jen's view that everything is possible. I think the difficulty for people who are already working in incredibly overstretched services is there's no capacity to think about how to do this differently. And unless there is some front funding that allows people the space to think and to pilot, or another area in Scotland who is supported to think about their adult population and how things could be done differently, I don't necessarily think we're going to somehow wave a magic wand and get lots of people being viewed through a neurodevelopmental lens by a workforce who aren't typically doing that, if that makes sense. I don't think we have enough linked up policy. I don't think we have enough clout to change things the way that we would love. We're very good at telling people what we would like to happen and how we think it should happen, but we have absolutely no time or power to make things so. And I think it's about trying to get a network of, people who are able to affect change at a much higher level, because it's got to come from policy down. I think the people who are on the front line in services are on their knees, and COVID is not going to make that any better. You know, mental health, although I think some aspects of mental health have improved, having been able to stop, you know, the relentless lives that some of us were living. You know, I do think there's the whole toll of COVID that will swamp adult mental health services again. So unless there's something that presses the pause button and gives other individuals a chance to look at how things could be done differently, and I don't think a paediatrician, you know, that's certainly not my job to go into adult services. I can, you know, help from a paediatric point of view in terms of what skills and experience we've got. But there needs to be a separate team that is looking at this and scrutinising what the impact would be if we invested a bit more and kind of front-loaded a system rather than constantly be trying to patch up holes in a dike. You know, we're not getting to the root of the problem, I don't think. Okay,
if we think about Scottish policy, then at the preventative end, we've got kind of the alcohol framework, and I'm assuming that those population level measures, looking at increasing price, reducing availability, reducing marketing, they will have an impact in terms of contributing to the prevention of FASD. In terms of rights, respect and recovery, which is the alcohol and drugs strategy, which is more looking at treatment and recovery, how, because it's mentioned in there, but how engaged do you think FASD kind of clinicians, practitioners are in terms of influencing where that goes, so that it's actually meaningful in terms of changing how services are delivered? And I will then come to you, Moira, and then to Chris after this.
So I've never heard of the rights, recovery and responsibilities having FASD in it at all. Jen, have I missed that in one of my absences?
I think something we found tricky, Eric, and this is just me speaking from being fairly new to linking with policy teams and government, is that we kind of expected that policy teams would interconnect, that had things in common. And we report a lot to the children and maternal health team, and I know that they communicate with alcohol policy teams, but I'm not quite sure how strong the interface is in relation to FASD in particular. I know the preconceptual framework has got a lot of work that would be really dovetailing nicely, but I don't know how strong those links are. And certainly we were speaking to people in you know, various alcohol forums that didn't know a lot about FASD, and people who know a lot about FASD, like us, probably don't know enough about all the alcohol policy and work that's been done. So I think that's definitely an area that could be strengthened, and I would be wanting to learn more personally.
And just to say, if we can help with that, I mean, perversely, our experience is that I think that collaboration is actually working better with COVID, and actually using policies such as Zoom has actually improved a lot of that collaboration and sharing of information. So there are opportunities from this terrible situation we're in at the moment as well. Moira, can I ask you to kind of come in? I've unmuted you.
Thank you. Yes, and COVID-19, wonderful natural experiment. I hope somebody's looking at it. I think for all the talk of joining groups together and linking things in for seamless working, at the bottom of that is the fact that we're human beings, and that this is a diagnosis which is also seen about judgmental and morality. And Eric, you said at the very beginning, you know, you said, please could people be respectful, basically, is what you said, and that was important. It was sad that it had to be said, but I think it still has to be said. But I do think that this is about morality. I do think it is about good-hearted professionals not wanting to bang women over the head even more when they have a child who has been damaged, by saying, yes, it was because what you did when you were drinking that caused this damage. And I think that we can't underestimate the way that can affect professionals from saying, if they have a choice of 3 things they have to join and add to their remit, this might well be at the bottom of the pile. That's it, if you're waiting for me to say any more. Eric, you're muted again.
I'm trying to unmute Chris, and I should unmute myself first. Thank you, Moira. I mean, I'm hearing that very strongly, that actually a lot of this is actually about thinking about people's human and life experience, and just treating them as human beings, and being just thinking about that through everything we do as much as anything else. Thank you. Chris, sorry.
Just a brief, and thanks to Moira for those comments that are born on 20 years plus of experience and exposure to all these difficult issues. That's okay, Moira. One thing that I've seen over time in a slightly different context in neurodevelopmental clinics in Fife over a number of years is the transition issue of children coming to 16, 17, 18, leaving school with a variety of problems, ADHD, ASD, FASD, and they tend to sort of drop off a cliff if you're not careful and not get the support they need. And even when one has referred on to adult psychiatry services to try and create some kind of ongoing support and transition, one of the responses one has seen has been, oh, well, this isn't really for us because, quotes, they do not have a mental health issue, which has been a bit disappointing. That's one aside. The other thing is, I think we've been working hard and have had trips down to York and London and around to chat to colleagues in the Royal College, trainee paediatricians, and we've made some progress there, but would hope to get more support from the Royal College of Paediatrics and Child Health around training and accreditation and recognition of the importance of training for clinicians. The other thing is that the SIGN guideline that we have heard mention, which is an important milestone, does mention adult assessments, and it just really makes it's not for adults, it's for children and young people. It does say that the same general principles should apply to the assessment of adults. And I think come back to this, as if we're looking at the prevalence of FASD that we assume and calculate is around, and there's so many undiagnosed cases that they are around us every day and everywhere, and they're getting into bother, and unless we pick up on that, then they're not the only ones that are going to miss out.
Chris, can I just ask you, Felicity, I know you're looking to come in as well. Chris, can I ask you about, or anyone else about, you said getting into bother. What do we know about getting into trouble with the criminal justice system? And
a certain amount of research coming out of Canada, the US and Australia, and looking at the prevalence of FASD in young offender institutions, e.g. in the west of Australia, and a sort of a well sort of quoted study from there. It was 30% of the young people there had FASD, mostly undiagnosed. So one wonders, and we have got together with a group of folk looking at the potential for looking at and trying to accumulate data around prevalence within the Scottish criminal justice system somehow or other, sort of screening. It was really challenging, screening populations in young offenders institutions and prisons for this diagnosis, because of course you might be looking at a plea and mitigation at the sharp end when they first get into trouble. But if you're looking at ongoing support that's going to make any difference and any impact, then it has to be informed by, as Jen has said more than once in her presentation, scratching at the surface, scratch at the surface and say, oh, crikey, I actually didn't appreciate that they can't remember what's going on from one day to the next. And they're so poorly organized and so impulsive. And they used to be thought of as having ADHD, but they maybe do, or maybe not. And the challenges that surround that, it's not easy. Nobody's saying it's easy, but I think it's a nettle that has to be grasped. If in the SHAAP context, there is some means of advocacy that can continue to lend pressure towards ongoing awareness raising and support and all that goes with it around FASD, that wouldn't go amiss. I have a certain sense, because my contract ceased at the end of December, a sort of unfinished business. And thinking selfishly, if that's something that one can leave to Jen and Sarah, then that's absolutely fine. And to the likes of myself and Moira, we have a lot still to say and contribute, but not perhaps at the sharpest end that we would wish it to exist in.
I think just for people to be aware that Rise Respect Recovery, there is work that was interrupted by COVID in relation to making it more meaningful in terms of action in relation to alcohol, but we are absolutely committed to being part of taking that forward. I'm conscious Felicity first and then Peter.
I want to say something on the back of what Moira.
Felicity, can you come closer to your microphone?
Oh yeah, usual problem. Is that better?
Slightly.
Is that better? Yeah, good. Okay, I'll shout a little bit then. So I'd like to ask Jen and about the sort of prevention aspect of their work, and I realise that it is one of the most difficult aspects of this, in terms of women not knowing that they're pregnant, women who can't stop drinking even when they know that they're pregnant, and also the whole pressure of society, as you explained, Sarah, at the beginning, to drink, whatever. But I remember a similar occasional seminar about 3 years ago, when a lecturer from Dundee University had conducted some research on women and drinking during pregnancy in various different areas. Fife, Ayrshire was one, I think, as well. I can't remember what the third one was. But one of the comments from his research stuck with me all this time, and it was a midwife who said that she had difficulty talking to her patients, the women, about drinking when she drank herself. And obviously what Moira was saying is that it's extremely important in that situation not to be judgmental. And I was just wondering what Sarah and Jen thought about this, and presumably, I mean, that was 3 years ago, probably training of professionals and midwives and so on, people working with pregnant women, has probably come some way since then, especially with the development of the SARN guideline and everything. But what do you think about that?
Okay, can I ask Sarah? Yeah, can I ask Sarah and Jen, do you want to hold off and kind of include this in your final comments? I think the main point is about judgmental attitudes by kind of care providers, but also how far people's own drinking to kind of, so if you're providing a service, how far what you're doing yourself inhibits you from feeling that you can give advice to others who might be doing not very much different from what you yourself are doing. I think that was the main point, Felicity.
Yes, that is the point, yeah.
So Peter, can I ask you for the last question, and then ask Jen, then I'll come to you, Jen and Sarah, to kind of round us up. Peter. No, you're muted still, so I'm trying to unmute you.
Okay, right. Is that fine? Can you hear me?
Yep.
Yeah. Okay. Yeah, I was. Well, first a comment. I think that one of the big challenges here, I think, actually is the level of expertise that you really need to do this well. And I think, you know, having seen Sarah and Jen in action in the SARN guideline and their team, I think that's actually one of the problems. There's an enormous amount of expertise in your team, your diagnostic capacity and the neuropsych assessment that is not going to be easy to replicate. I know I'm piling the agony on you, and you've thought about this for a long time, and it actually says in the SARN guideline that what happens in Ayrshire should be generalised out everywhere. But you know, there's a huge skills gap, and you'll know that better than most. So I think that's a challenge. It's a common one in medicine, you know, what's general and what's specialised. And having heard not just yourself, but also the educationalists who work with you, you know, again, they've got an enormous amount of experience, and whether average classroom teacher can replicate that, I think, is a big question. But actually, my question was going to be from the same session that Felicity was talking about, Andrew Simons. And my take-home message from that is that their study of doing a diary type assessment of maternal drinking produced a much higher identification level than the standard, audit screening tool. And I say this as somebody who's advocated the use of those brief screening tools for adults in general practice, just to get people to ask the question. But I think their work, and it wasn't a surprise, showed that if you do a diary type thing, as Sarah was talking about Christmas and her father, what were you doing at Christmas time? Then, they identified considerably higher levels of exposure than your kind of normal ACE or tweak or the other things that we identified. So I think that's my question really, is what is the best practice in antenatal practice? Because my understanding of the outcome of the SIGN guideline, and I think this came from the Canadian guideline, is that unless there really are very clear-cut sentinel features, you shouldn't be making the diagnosis without a reliable history of maternal consumption. And I suppose the question is, how do we best get that assessment made so that the diagnosis of FASD can then be made?
Okay, Sarah, Jen, can I just give Liz one last question and then ask you to take those two questions and Lizzie's question together and also make your final comments? So, Liz.
Hi, can you guys hear me?
Yep.
Good, okay. Actually, my question adds on really nicely to what Felicity and Peter both just said, and it was kind of a more general question about what has been called gender transformative approaches to prevention. So, this idea that maternal drinking is solely a women's issue or the issue of the mother themselves by themselves. And I just wondered what you thought about kind of approaches that seek to educate partners and kind of supportive family contexts, whatever those contexts might be, as a way of supporting mothers in this situation and kind of making them feel like, taking away a bit of that stigma perhaps, and kind of making it a societal issue rather than a quote unquote women's issue. So that was my question.
Okay, thanks. So Sarah, shall I ask you to take that?
I was going to say, Jen, do you want to answer that aspect in relation to dry mester and your thoughts around stigma, and then maybe I'll pick up on Peter's comments about specialist services?
Great.
So Jen, you go first then.
So what Elizabeth was saying there is absolutely on point. I think that's exactly why we use our strapline as FASD is everybody's business, and we certainly, when we do our training, talk about the paternal influences as well, in terms and in our awareness raising package, talk about the effects of alcohol on sperm as well as on eggs, and those two coming together, and the in utero environment being about somebody in a societal environment where there are cultural pressures and a need for education across the board. I think that although us in our team have that, and we have that in our train the trainer awareness, I think when it comes to people thinking about going for FASD training, and midwives or people who are going to be doing ABIs or alcohol screening, there is this sort of gut wrench reaction of, oh gosh, I need to ask women about alcohol use in pregnancy. And there is a real hesitation about that, and midwives have openly said, I feel really uncomfortable about this because I don't want to damage my relationship with this mum. And that's absolutely, we need to hear about this, and we need to think about our training packages for those professionals really carefully and co-create them with those professional groups. And I think this is a whole load of work that our team hasn't managed to do. We were never funded fully to do that extent of prevention work. But Lisa Sholin and Moira and colleagues have done lots of lovely research that's informed us about what that could look like, and we've written that up in our vision document that will be handed to government in September at the end of our funding. And we really hope that that's a piece of work that numerous policy areas and professionals better equipped than us can take forward, and we need midwifery colleagues to be at the heart of that, and also women to be consulted with about how they wish to be asked those questions and in which way they want to involve family members. But yeah, I think the education needs to be for everybody, and yeah, if people are interested in talking about that further, I'm really glad that we've got this forum to do that in. I know that we're short in time, so I'll pass to Sarah for further comments on that and the other aspect of the question.
You know, just before you do that, can I just kind of just highlight some chats that have come in? So Liam kind of raising the issue that work that he's been doing with over 18s, that we just may not be recognising that FASD is part of the issues that they're dealing with, so a real kind of problem in terms of lack of diagnosis. And Nikki talking about in terms of awareness raising that there's a wider population approach is obviously a continuing discussion which will continue. Can I just ask you to kind of give us your last kind of reflections, kind of comments, recommendations?
Oh, so I suppose for me, the chance to collaborate with people in terms of there's so much work to do. This is bigger than a day and a half a week consultant paediatrician and 3 days a week clinical psychologist. We need investment in substantive long-term posts for, as Peter said, folk who have developed experience in this area that will go to waste if it's not kind of kept funded and in a long-term way. I also wanted to say a little about Peter saying it is a really specialist area, and I think it has taken us time to get to where we are. However, FASD is too big a problem to be specialist, and that's what it boils down to. We need a generic workforce that's able to work to certain guidelines, to be trained and supported efficiently and effectively, and have those people who have maybe a little bit more expertise in working with more complex cases to advise them on how to get their skill set up. We'd done none of this 6 years ago. You know, Jen and I are just, I don't know how people would describe this. I'm sure there's lots of adjectives, but you know, I think we just kind of got stuck in, and I feel that people who are doing it now have so much more than we had when we started. You know, they've got a guideline, they've got resources, they've got you know, other things that can support the families after diagnosis. But we need some sort of overarching strategy that takes into account all the different areas this affects across the lifespan and across all the different policy groups. And that's something that Jen and I can't do together, and it's something that we would welcome, you know, somebody taking the lead on, with us being able to kind of put in what people would find helpful. But you know, our expertise is in working with the families and the diagnosis and supporting other clinicians, but there's a whole heap of work right across public health and prevention and adult mental health, etc., that we kind of need a much larger group to be focusing on, I think, to get any long-term impact from what we've done.
Listen, thank you. I just want to kind of, we had a colleague, Eleni from Greece, who's saying that there are cultural contexts there that make some of this discussion even more difficult than it is here, but also agreeing that actually kind of sharing, I think generally, I've had a really kind of strong theme through all of the contributions about working across communities and scaling generic workforces rather than treating this as some kind of small specialist issue. But we're on a path to kind of getting there, but I do sense a real commitment from these discussions that we do want to work together on that. Jen, Sarah, I can't say how wonderful that was. Thank you everyone who's joined us. You can react, there's a reaction button, so if people want to react, please do so. I'm doing that just now, otherwise you can just do that. But thank you very much, and looking forward to continuing this discussion. Thank you very much indeed.
Thanks everybody.